So, pop this on. Can everyone see that?
Yep, perfect.
Great. So today's presentation is on pelvic and spinal masqueraders. So we're going to take you through why it's important. Think about those assessment skills, both in terms of your subjective assessment, your objective assessment, and then the thought on what are the most sort of common masqueraders. There are so many, as you can imagine. So I've focused on 4 of the key ones that I think are important to have at the back of your mind when you're looking and seeing people with either lower back, spinal pains, and then the sort of pelvic element with it as well. So just briefly before I move on to, I'm Rosie. I'm a pelvic health physiotherapist based in Bristol. I am now full-time private. I was in the NHS for a number of years at St Michael's Hospital and attached to the BRI within the women's health team. Before I moved into women's health, I was a musculoskeletal physiotherapist. And the role of a pelvic health physiotherapist is, I like to think of it as a physio that is interested in the area almost between the ribs and the tops and of the thighs. So we're interested in the functions within that area of our body. We're interested in the movements, the joints, the muscles, and that whole system and how it works with our sort of musculoskeletal setup. So you can imagine that we see lots of anything abdominally, we see any of the aches and pains within that area, and then what we're sort of known to be seeing more commonly is the pelvic functions that happen within that area. So any changes to our bladder, our bowel, our sexual function, and potentially the upward lift and support to those structures too. And there are lots of people that will present with changes to bladder and bowel symptoms predominantly, and it's our role and often the role of who I can see are here today, lots of FCPs and GPs and paramedics who might be presented with people with changes in that area too. And it can be quite, I always think of the pelvis as, particularly for the physios that are here, we were never really taught about it in our undergraduate or master's degree sort of education. And therefore, when there's people that present to you with back pain and then they tell you about changes to their bladder and bowel, it can feel like everything must be a red flag because that's what we've been told about with, cauda equina and all of that sort of stuff. And it can be, and it's really good to be aware of it, but it can also be just changes as part of the pelvic floor changing or other things. So sometimes you can sort of hone in on just the pelvic changes, and hopefully from today you'll be able to sort of know about what normal changes might be, and then also from their subjective and your objective assessments be able to sort of pull out the things that maybe match or maybe don't match, or you just sort of think, okay, this is painting a bigger picture and this is where I want my sort of exploration of or treatment to go with this particular person in front of me. So why is it important for you to start understanding a little bit more about spinal and pelvic masqueraders? There's many reasons. The main reasons I think are that you have got a huge amount of people that will be presenting to you, and again, sometimes you can become a little bit complacent in thinking, well, this must just be a lower back presentation or a non-specific lower back presentation, or this person's postnatal, these changes are relatively normal for them, or this person's in her 80s, therefore bladder and bowel symptoms are not, relatively normal for her to be having them. But actually, so your assessment skills have to be suited for a huge range of people that you're seeing, and it's your breadth of knowledge in common pathologies can affect so many of those people that you're seeing. So it is quite challenging in itself to sort of hone your skills, but it's important to have all of these things at the back of your mind whilst you're sort of assessing this patient. The cost to the NHS is quite huge when it comes to either misdiagnosis or delays of diagnosis, particularly with cauda equina compensation. And in between 2014 and 2016, £68 million was paid for compensation for patients that had a delay in their diagnosis or misdiagnosis. And not only that, but actually, patients can become frustrated with delays in inappropriate treatment or being exposed to unnecessary treatment for the wrong diagnosis. And that can be both expensive financially for them and for the NHS, but also it can have big sort of psychological repercussions for them and for the clinician too. And, these are opportunities for, with correct diagnoses, diagnostic errors, and then those near misses, they can all be used as opportunities to learn how to improve the work system and that diagnostic process too. So yeah, it is important to be able to have the skills within us to differentiate between what you might be seeing. So assessment skills is a big part of what we need to have to help us navigate this area of health. Subjectively, I always think that actually the time spent during the subjective assessment is time very well spent. I know, particularly working within the NHS, that you don't always have the luxury of time with the patient in front of you. But you can get so much from that subjective assessment, and you can pull out, if you're able to, you can pull out bits of information which can hugely help then guide or prioritize what you want to look at objectively, just by maybe investigating or probing a little bit further with some of the information that you might be wanting to find out about. This area of health that we're maybe going to be asking about is still, unfortunately, quite a taboo subject. Talking about somebody's bladder, bowel, sexual function, or changes that they might be experiencing within their pelvis or their abdomen or their back can be quite unusual to talk about, and they might not even be talking to their nearest and dearest about it. So then to come in front of somebody that feels like a stranger, but is a medical professional, to then start talking about, how frequently you're urinating and what your bowels are like, and your sexual function and some intimate details about that, can feel quite strange. And quickly building that rapport with somebody is really hard, and it doesn't always happen. But if you can, one of the best ways to actually sort of get that is explaining to them why you're asking these questions, and giving them the confidence that and reassurance that you're not doing this for any other reason than to just help guide what you want to be looking at or what you want to be ruling in or out about why they've come to you in the first place. So sort of caveating, I'm going to ask you some questions that feel quite personal. You can give me as much information as you want, but the more information you give me, the better able I'm going to be able to sort of then start building a picture for why you're here and what we want to be looking at, can be a really useful phrase to just have to help them sort of understand why you're asking these questions in the first place. It's a time, and particularly as a pelvic health physio, I spend for an initial assessment an hour with women, and it wouldn't be unusual for me to spend 30 minutes up to maybe even 40 minutes, which I did yesterday, talking about the subjective assessment and the subjective history. And I know you do not have that time, and that's quite unusual, but actually sometimes not feeling pushed to, if you don't have the time in that moment to do the objective assessment, saying, you know, we've spoken a lot today, I want to assess you objectively, but maybe we've got the capacity to bring you back in the next few days to do the objective part, or just from subjectively, let's do X, Y, Z first, and then we'll look at the objective assessment next. But yeah, this sort of time, you can always come back to this information that you're gathering in that initial assessment and subjectively.
Rosie, we can't hear you talking.
About
the last minute or so.
Sorry.
Oh, I can hear you talking. I wonder whether it might be you. Somebody else. It might be yourself personally.
Might be location.
I don't think anything's changed. Can everyone else hear me okay?
Yeah.
Yeah, I can hear you
Everybody else
fine.
can hear you okay.
Okay. Sorry, I don't know what will have happened, your end with that. But so don't rush this part. And the information that you're gathering can really help to guide the rest of your appointments if you have them with this person, because you've always got this body of information about them, stored and documented about them. The other thing in the subjective assessment that is actually really crucial for some of the presentations we're going to talk about is actually the timing of the onset of some of the symptoms. So knowing about the acuteness of them, or how long they've been there for, can really then help you to understand the nature of the onset and or what you again want to be looking at. So you know all of this, but just to run through some of the questions that we might ask about a bladder and their bladder function, we want to be thinking about frequency of urinating. Normal frequency for emptying the bladder in the day is between 5 to 8 times throughout the day, or that should be roughly sort of being able to hold for an hour and a half, 2 to 3 hours ideally. If you're asking somebody to do a bladder diary to improve your depth of knowledge about their presentation, then normal voiding throughout the day is about 150 to 250 mils each urination. Urgency, you should be able to hold your urine, and you should be able to have at least 20 minutes before you really urgently need to get to the loo. So if anyone's going much quicker than that, or their urge is much more frequent, then that would be abnormal, or something to be thinking about looking into. The control, so you should be able to control your ability to urinate and the flow and the stream. You should be ideally drinking between 1.5 litres to 2 litres of fluid a day, but actually it's roughly, I think it's 30 mils per kilo of body weight. So if you're heavier, then you should obviously be matching your fluid intake to your weight. You should have the sensation of both needing to go to the loo and in passing that urine, so you should know that you're urinating when you are. You should be able to void and know that you can empty it and start the stream of flow of urine. And there should be no pain both in your bladder and then whilst you're urinating at your urethra. So any changes to that, those are sort of the questions you want to be asking throughout their sort of bladder control and bladder function. In terms of bowels, you want to be noting any recent changes. This is particularly important for one of the presentations we're going to go through, particularly a recent change of constipation, which might sort of suggest poor transit of that gut through your bowel and changes to the sort of muscle function of how of the small and large intestine. You want to know if there's been a change, if their pattern is normal for them. So normal is anywhere between 3 times a day to every 3rd day. And we probably all know about the Bristol stool chart, that lovely chart. The consistency of the stool, ideally you want it between a 3 to a 5 on that chart. So any looser movements or more constipated movements, the 1s or the 2s, we just want to know if there's been change to that. Can they control it? When they get a sense of urgency, are they again able to control that? Can they hold wind and flatulence? Has there been an increase in production of that? And again, is there any pain both in the moments of becoming urgently, getting a sense of bowel urgency, and then defecating? Is there any pain with that as well? Sexual function can sometimes be one of the topics that's hardest to talk about or that we brush over, but it can actually be really useful, particularly in the presentation of cauda equina, if we can ask about it. And again, it might be that you caveat asking about it by saying this is important for us to understand any changes to your pelvis, you know, in the presence of this newer back pain or the radiculopathy that we're talking about. So have there been any changes to function? And also remember that even somebody that isn't sexually active with a partner can still be sexually active with themselves. And so if they haven't got a partner, it's still worth asking if they are sexually active themselves and whether they've noticed any changes to that. So are they able to get aroused? Are they able to orgasm? The pelvic floor is a really important muscle in being able to orgasm. Can they tolerate penetration? Have there been any changes to pain, both superficially and deeper? And are there any changes to pain after sexual activity, which can help with sort of the visceral presentation that we'll go through? And then changes to sensation. So sensations of bladder and bowel urges, sensations of passing bladder and bowel or feces and wind, and then that sensation of clothes in the area or exactly like a saddle, you know, any of that sort of saddle presentation. Can they feel that? Can they feel touch? Can they feel wiping after urinating or defecating? So, you know, asking about those, and this builds such a useful picture for you to then think, okay, great, we're going down a pretty standard lower back assessment here or a pelvic assessment, or okay, there's some things that I've just picked up on, and you're just again building this lovely picture of what you then want to look at both objectively or with diagnostics. So objectively, work within your scope of practice. Obviously, I'm a pelvic health physio, so I've done additional training to do some of these assessments in more depth. Doctors, GPs obviously will have done as well, but if you're a sort of FCP, then just work within the scope of practice that you are comfortable within, and refer outwards or seek help from people that might be able to add different elements to your assessment. Always remember that a full lower limb neurological examination is really, really useful, and the documentation of that as well is really essential, particularly for forward referrals or sending to A&E departments and things like that. You can always do a saddle anaesthesia assessment too, so thinking about the S1 to S5 dermatomes. Anal tone will go through, but actually in terms of the cauda-equina presentation, they're actually these sort of tests, so anal tone, bladder scanning, and assessment of residual post-void volume. They're used for cauda-equina assessment, but the evidence for their use in predicting cauda-equina is actually not very strong. And particularly anal tone tests have been shown to have very poor reliability and poor correlation with a positive MRI when finding cauda-equina. So they're useful to have, but often now BAS, the British Association of Spinal Surgeons, is actually recommending not necessarily not to do them, but just to be aware that there's other things that can add to the picture. Then thinking about for sort of more neurological presentations, you're to be able to decipher between a radicular pain or radiculopathy or something like MS, which we're going to go through, being able to document and have assessed like touch, pinprick sensation, somebody's coordination, heel to shin and finger to nose, and then also those additional assessments that we sometimes get out of the habit of using, are plantar response and the Hoffman's reflex, both with upper and lower limb. So if you are within a sort of GP practice and you haven't used them recently, then just ask one of your colleagues to just say, would you mind just going through these with me, you know, so that we're feeling like we can use them if we need them, because they can really, really help you to then understand again what your thinking is for this person that's in front of you. So the as I said, we could go through so many masqueraders, but I think it's really important that we narrow down the ones that we are going to go through, and that you are really thinking sort of these are the sort of most common ones that I would say run through my mind during an assessment, and the chance of actually seeing them are still really, really low, but the presentation or their potential presentations with spinal and pelvic patients is quite high. So I think these are the ones that I feel that you'd be best to know about. And if there's anything else that if you've got any patients that you've sort of seen or want to go through, we've got time at the end to sort of have a little bit of a case study presentation if you want to. So, oops. No, not that. I need to turn my camera off. So cauda-equina, every medical professional I'm sure knows about this, and I'm not trying to teach grannies to suck eggs or whatever the phrase is, but it's defined as the patient presenting with back pain and or sciatic pain, and they have a disturbance of their bowel, bladder function and or saddle or genital sensory disturbance with unilateral or bilateral leg pain. So anyone presenting like that should be suspected of having a threatened or actual cauda-equina syndrome. There are, since 2016, there are 4 classifications or 4 stages of cauda-equina. You've got CESS, which is the suspected bilateral radicular pain and progressing, or it can be a progressing unilateral pain, so it doesn't have to be bilateral. You've got CESI, which is the incomplete urinary difficulties of neurogenic origin, altered urinary sensation, loss of desire to void, poor urinary stream, that should say, and need to strain or micturate. You've got R, which is the retention. So you've got painless urinary retention and overflow incontinence. And then you've got complete, which is the loss of all cauda-equina function, absent perineal sensation, patulous anus, and paralysed insensate bladder and bowel. So the S and I are your least severe, and the R and the C are the more severe. Oops. So yeah, current guidelines are there should be this low threshold for investigation with an emergency MRI at the request of the clinician, and the current guidelines are quite clear about the need to perform this full neurological examination, which we've spoken about, of the lower limbs, and this gives a really, really good indication of the possible radiculopathy. And then the guidelines from BAS are also suggest that tests of saddle sensation and anal tone are performed, but like I said earlier, they're actually not. They don't have very good reliability or correlation with the findings that we see on the MRI. And yeah, so actually if you suspect cauda equina, then it's really important that you actually do and you can send for an MRI to a 24-hour hospital that is able to do that. And if if you're sort of outside of that scope, or you don't feel like you can make that decision, it comes down to, if you're a physio, the person to make that decision about same-day scanning if you think that that's needed. So if you're a physio and you're not you're within a sort of department or area that doesn't have access to 24-hour scanning, then it's really important that you're referring that person on to a hospital or department that can make that decision and giving clear documentation about why you feel that that's needed. Obviously, and I'm sure this is again something that doesn't need to be explained, but each sort of department that you're within should have a very clear written and agreed process about what to do in the case of seeing somebody with cauda equina. So yeah, you don't need to discuss this with the spinal services. It should be something that if there's a clinical indication to send somebody for an MRI, that it should be done. And that obviously there's the urgency of this with taking precedence over those routine cases, because the outcomes of treating or of surgery are very good generally for the first two. So going back to these classifications, S and I, suspected and incomplete, generally the outcomes post-surgically will be relatively good for people with a suspected or an incomplete, but actually the ones that have retention or complete are very poor. So time is really of the essence when it comes to referring these on. So yeah, the outcomes are very poor. They actually say that you may as well, when they're presenting and they've got described symptoms of the retention or the complete, they're actually no longer red flags, they're actually white flags, because we need to almost surrender because the outcome is so poor with that. So it's really important to get this, get somebody presenting like this an MRI as quickly as possible. And they often, patients with symptoms in retention or complete generally won't recover bladder and bowel function or the sensation that they might have lost following surgery. But the prognosis is relatively good for S and I. So the other thing that the other masquerader, I suppose, is multiple sclerosis. People with suspected multiple sclerosis will have changes often to their bladder and bowel function. So that's how they can come in front of pelvic health physios or physios within the role of the CP or GPs. And so again, when there have been changes of pelvic health nature, then it's something that I would always have at the back of my mind, particularly if I'm seeing this person for a while and things aren't improving as I would expect them to. So there are around 100,000 people in the UK with MS, and there's 5,000 new cases per year, which equates to about 14 cases per day. Women are nearly 3 times as likely to be affected by men, and symptoms will usually appear between 30 and 35 years old, but often diagnosis doesn't really happen until often about 45 years old or 64 years old. And the highest rates of MS are actually found in Scotland or Northern Europe, Australia and New Zealand. So I think they're thinking that it might be a vitamin D deficiency. But again, it still does happen in the southern parts of the UK. Clinically, the presentation, as we know, can be very varied, and very often people will come into the sort of MSK category of a presentation, but then there may be some of these bladder and bowel symptoms linked to it as well. And particularly the early symptoms may mimic musculoskeletal disorders, but then there might also be other things like the sort of transient visual disturbances, or the other sort of more traditionally recognised symptoms of it. Some of the bladder things that they might have are frequency, urgency, urinary incontinence, and or repeated urinary tract infections. And that should sort of start to maybe raise the clinician's suspicions, but also constipation is quite common, and an early sign of MS as well. Yeah, most of the patients we see obviously won't have MS or a neurological cause, but it should at least be considered. And thinking about that, going back to that subjective assessment, it might be something that you add into your subjective assessment by thinking about either family history, fatigue, weakness, sensory changes, bladder issues, balance issues, memory issues, and then that cognitive impairment as well. Diplopia, blurred vision, pain, and pain with eye movement. So it's just, yeah, thinking, like I said at the very beginning, it's so easy when somebody comes to you with bladder and bowel problems to almost focus on that, but actually having that ability to sort of zoom out a little bit and think, okay, they're part of this picture. What else can we add into the picture to sort of think about, or yeah, sort of work alongside. So the sensory changes, using your objective assessment now, is now a really important part to actually help distinguish between the cause of those sensory changes. And what you're wanting to do is really distinguish from a radiculopathy, because the sensory changes will tend to be more widespread, and they'll have a non-dermatomal distribution. Weakness for somebody with MS will also tend to be more widespread, and it won't have that specific myotomal pattern as you would expect with a radiculopathy. So yeah, that comprehensive neurological examination is really useful, and that's again where we use our in-depth sensation testing, so light touch, pinprick tests. We use the power and the reflexes to assess that in full. And then thinking about that coordination, so heel to shin, finger to nose, and then tone as well can be performed. And then thinking about those upper motor neuron lesions, so plantar responses and Hoffman's reflex in both upper and lower limb. And that really then helps you to build this really clear picture of, okay, we're thinking more radicular pain or radiculopathy, or are we thinking of that upper motor neuron sort of presentation? And again, starting particularly from a physio to assess in this manner can be quite worrying for somebody who just thinks, well, I'm just coming to you with a bit of, back pain or some MSK pains that I've been experiencing, or some bladder and bowel symptoms that I've been having. I thought, why are you doing all of this? And it's just trying to explain that you're trying to build this picture so that they get put in front of the most appropriate person for them. So communication and explaining what you're doing is so important when you're starting to then think about these masqueraders. So any questions so far on Cauda equina or the MS presentations? Lily can always.
Nothing in the chat. Has anybody got any questions? No, I think you've covered it quite well.
Okay, we'll continue. So the third one is the axial spondyloarthropathy, which is always a bit of a tongue twister to get out. So this is obviously the term that covers anything inflammatory or any of those inflammatory diseases of the spine. So it can include the radiographic SBA, which are changes that are seen on X-ray, the ankylosing spondylitis, and then your non-radiographic SBA, which are not visible on X-ray. You might also find that peripheral joints might be affected in related inflammatory conditions such as psoriatic, reactive, and enteropathic arthritis. And around 200 adults in the UK suffer from axial spondylitis. So it's sort of is much more prevalent than previously thought. It predominantly will affect younger people, so people between aged 18 and 45, and the average age of diagnosis is actually 24. And it was traditionally thought that it affected males more than females, but actually the NICE guidelines from 2017 have found that the sort of prevalence is actually comparable to men and women, but it's that women have or often take longer to become diagnosed, and it's not really sure why. But it's probably because women don't present in such a classic way as men do. But it can take women 3.5 years longer to get a diagnosis than men. Men apparently are more likely to exhibit radiological changes, and women are more likely to be sort of functionally limited, which then might not get explored. Yeah. So symptoms with this can obviously present in a variety of ways, but this is probably one which is they're less likely to have those bladder and bowel changes like they might with Cauda equina or with MS. But this is the person that is actually more likely to present with SI joint pain or buttock pain or that lower back pain that you're just not quite sure why it's presenting or where the source of the problem is coming from. And again, I would say that women either during pregnancy or postnatally are the ones that might fall into this misdiagnosis or not get the right diagnosis because we're classifying it as a pregnancy related or pelvic girdle pain or postnatal change as a result of being postnatal, looking after a baby, and repetitive movements. So it's those sorts of women that I'm really bringing this one to light with. And again, it comes back to our style of questioning subjectively that can really help you to be able to start bringing up those little light bulb moments of thinking, this pattern is different to a pelvic girdle pain presentation or a postnatal sort of lower back pain presentation. So thinking about those sacroiliac, thoracolumbar spine pains are generally the most common problems associated with this presentation. So the line of questioning, thinking about your morning stiffness presentation, pain on rising that lasts longer than 30 minutes, Generally, symptoms might be improved with movement, but will then grow worse with a prolonged inactivity during the day, which can happen again with breastfeeding. And you can sort of think, oh, well, you've been sat breastfeeding for a while, you know, what do you expect? And then patients may wake up at a regular time in the second half of the night in pain. And another thing is that the pain will normally be eased with non-steroidal anti-inflammatory medication rather than a paracetamol or something like that. Yeah, there may also be other inflammatory manifestations that are generally more systemic. So thinking about concurrent enthesiopathies, so tendon swellings or irritations, so things like plantar fasciitis, Achilles tendinopathies, other tendinopathies like tennis elbow, lateral hip pains, and asking a history of that might also then help your direction of where you're going and where you're thinking about diagnostically helping this person in front of you. Okay, so the final one we're going to touch on today is this viscerally referred pain and symptoms. So this is a lovely chart of pain that we might have, which obviously all of these areas we can have musculoskeletal pains within, but your ability to question somebody about other symptoms they might be getting and thinking about the locality of the presentation really helps you to sort of rule in or rule out other things that might be going on. Really interestingly, and maybe quite randomly, and I've had 3 women in the last 2 weeks probably with a really painful mid-back and a very sore upper abdomen, and they're all relatively newly postnatal, and they've all got gallstones, and that's now been found out. But it was the one of them that then had a scan for it, and then that helped my ability to quite quickly encourage the other 2 to then go and have the appropriate diagnostics for this, a very similar pain presentation. So I can't find anything about the sort of postnatal nature of hormones and things like that being making you more prevalent to develop gallstones. I think there is, but it's just interesting that you could so easily brush that off for a woman and say, well, you're breastfeeding, you know, it's like, you know, an area that you're going to get that mid-back pain in. But yeah, it's just having that ability to think a little bit more outside of the box. So this is a nice chart to just then think about all of these different pain distribution areas, and then there's possible symptoms that they might have with it. This presentation will be sent out to you all by Lily at some point, so you will have this to come back to. But if you look at sort of the ovaries, uterus, bowel, bladder, they're all areas that we're going to be seeing as MSK physios, as pelvic health physios, of that sort of lower abdomen, pelvis, and then upper thighs and things like that. Visceral pain is thought to be responsible for 2% of all lower back pain. So it is there at a very small amount, but it is, again, something to just have at the back of your mind when you're asking people about their presentations. And then also thinking about that clear questioning about the function of that viscera that can refer to the area where they may have that pain. So asking about any ovarian history, if we're talking about the abdomen, or uterine history, or bladder history, or bowel history, and being a bit more specific with your questioning if you're thinking about that. The other thing to think about is that the visceral pain is actually very often described differently to musculoskeletal pain. That generally people will report that there's a much more diffuse or a vague pain that's quite poorly localized. Whereas if you think about lower back pain, you can often be quite specific about, I get X pain on X movement, or I struggle to do X thing. Whereas this sort of visceral stuff might just be there. You know, for those that can relate, period pains, you sort of know it's there all the time, and it's this sort of diffuseness to it. And generally pains like this will start in the midline and then radiate peripherally, whereas often musculoskeletal pains will be a bit more peripheral and then might go to the midline. Yeah. Visceral pain is also often associated with this autonomic symptoms, and might have sort of affective reactions from the patient, which can then further sort of complicate the diagnosis. And yeah, thinking about the sort of similarities, there are similarities between somatic and visceral pain, but the key difference to help explain the nature of the presenting, there are relatively small numbers of afferent nerves from the viscera, which account for about 10% of the total afferent nerves reaching the dorsal horn before connecting with the dorsal horn. Yeah, sorry, I've got a bit lost with that. So yeah, it's just thinking about the pain presentation and how it can be sort of more yeah, visceral rather than that somatic presentation. So when thinking about this visceral pain, you really want to be thinking about that sort of clear examination of the abdomen, and that can really help for you to establish your diagnosis. And again, from a sort of musculoskeletal physiotherapy point of view, we're not often taught how to assess the abdomen in full during our training, and it's often only in being mentored by somebody or observing somebody doing it that you then get that better and clearer understanding of how to assess an abdomen. But physiotherapists and paramedics and GPs and nurses, we all have really, really good observational skills, and it's using that. I always think that the abdomen, we really need to use those observational skills a lot more to then help us pick out if there's something that isn't quite right or we want to explore a bit further. And there is an easy skill to also add to our assessment. So we really want to inspect, and you're looking for asymmetry, lumps and bumps, post-operative scarring, any signs of injury, flank bruising, skin changes, you know, any little capillaries or blood vessels that might have changed, any pulse or pulsatile masses. And just having a look and just seeing what it looks like without touching it. And then during your palpation, it should be sort of structured and methodical in how you do it. I often start from the lower right side of the abdomen and firmly press in sort of 4 parts of the abdomen from the right side. So right lower, there right lower, right upper, left lower. And you're wanting to feel for pain in any of those areas, which there often can be, but it's asking them if it is their pain. And then any firmness or any of these sorts of like masses within the abdomen. And it's trying not to rush through it, trying to do it with enough pressure that you can recreate that pain, and then monitoring any sort of signs that they're telling you or things that you're noticing throughout that assessment. Visceral pain is really common, and spinal pain of a visceral origin is also relatively common. it's actually more common than the sort of spinal red flag pathologies that will occupy our thoughts during assessments. But it's often less often considered in differential diagnosis of spinal pain. So being considerate of the possibility of a spinal referral and the addition of expanding your sort of subjective questioning and physical examinations will really enhance the detection of that and its management within that GP setting. So actually, this one is probably one that we think of the least, but is potentially the most useful to be aware of out of the four. So things to be reflecting on and taking home from today's session is take time with your subjective history taking. It's a really, really important part of what we do as clinicians, and time pressures within the area that you work in often might mean that you skip over it or you rush through it in a bid to then assess them objectively. But actually, if you can use that time, and remember that also subjective history taking can continue to happen during an objective assessment, but if you can really think, particularly when people are coming to you with spinal, lower back or pelvic pains in and out of the presence of bladder and bowel problems, if you can start thinking, okay, I want to ask the timings of these, I want to ask sensation, I want to ask the sort of more upper neurone presentation of balance or family history, I want to ask that sort of nature of the pain, how it all happens, then you're going to be painting this amazing picture that will really help with your appropriate diagnosis of that person in front of you, and then therefore the appropriate referral to either the right person or for the right treatment. Think of that person holistically. Use that sort of detailed objective assessment, and there have definitely been times in my career where I haven't practiced some of those objective assessments as much as I would have done. I know that probably being in a hospital in a neuro department, I was doing the sensation testing a lot more. I was doing the sort of plantar reflexes, Hoffman's a lot more. So if you're feeling de-skilled from any of those objective assessments, then just ask your colleagues to just go through it with you and build your sort of confidence back up with using them, and also build your confidence up with explaining to the person in front of you why you're using these to help build a picture of their presentation. And yeah, that sort of early identification of these things. Remember that these are often the lesser seen things, but it's having that knowledge of what you might be seeing and earlier identification of them will really help with the treatment of the pathologies and then improve that patient outcome as well. So we have got the references at the end of this, so you can always go back and have a little look at them. But are there any questions at all from today's session? We've got time, and like I said, I'm also more than happy to go through any case studies or people that you have got that might have come to the front of your mind that you're seeing clinically and you want a sort of opinion on of what assessment you might do for them or referral pathway.
There you go. Nick says, do you have any thoughts on persistent coccyx pain beyond a coccyx pillow, posture, activity modification and analgesia, which is fairly common in primary care?
It is very common in primary care. Obviously, I would want to know sort of like the history of that person, but the coccyx cushion I often recommend is not the sort of ring donut one that you would often think of with coccyx pain. I would recommend a sort of wedge-shaped cushion with a U cut out of the back, and that really just helps to get that pressure off the coccyx. But the problem with the coccyx is that you have got so many muscular attachments going into that coccyx. You've got your whole pelvic floor, and if you were attended the last session I did, you would have learned all about that pelvic floor anatomy attaching into the coccyx. You've then got loads of the glute attachments attaching onto the sacrum as well. So it's constantly in use. That coccyx is always being used and sort of pulled upon by lots of the muscles. And then weight bearing wise, we're always using that as well. So it's a really, really hard area to actually get settled down. Sounds like you're doing everything that would be like I would have already thought of. It could be pelvic floor related. It could also then be sort of, depending on their history, pudendal neuralgia, where you've got that sort of pudendal nerve irritating the coccyx as well. So there's a few other things that might be at play. If you haven't had much improvement, I would then probably refer to a pelvic health physio just to add a layer of assessment to it, where we can then assess the pelvic floor and see if it's that muscle that's causing the pain and the problems. I hope that helps.
Brilliant. We got any other questions? Quiet audience today. Probably everybody's behind the camera having lunch.
Yes, exactly, before their next patient.
Well, thank you, Rosie, for a very informative session. It's it's a lot to cover in 1 hour, so thank you very much.
Please do. Oh, sorry, let me. Yes.
No, it's fine.
Sorry. What